Welcome everyone to our afternoon session, session 3. I hope you were able to enjoy some of the posters. It may just have been my own technical challenges getting in there, but if you weren't able to get into a conversation with the presenters, I would encourage you to still review the posters and consider chatting with them so that you have an opportunity to engage around the work that has been really interesting. This session is with Mel, opioid agonist treatment and the opioid crisis. Dr. Kahan is an associate professor in the Department of Family and Community Medicine at U of T. He's medical director of the Substance Use Service at Women's College Hospital and medical director of the PHI program. Over the years, he has written many peer-reviewed articles, guidelines, and educational publications on addiction-related topics. His main interests are primary care and addictions, opioid agonist treatment, medical marijuana, and medical education in addiction. I'm so pleased that he is able to give us this talk on a critical approach to the opioid crisis. Just a reminder that if you have comments or questions, to please put them in the chat. We'll save them for the end, and I'll be happy to pose your questions. Thanks so much.
Welcome. I'm going to talk about opiate agonist treatment specifically and the opiate crisis. My only disclosure is that I receive salary support from the Ministry of Health as medical director of PHI. I won't go into this too much. We've talked about it at length today. Just again to emphasize that the crisis is here and it's getting worse, continues to get worse. Every public health unit in Ontario is affected and is seeing increases in overdose deaths, but there is wide regional variations. The northern public health units have by far the greatest per capita death rate and the greatest increase in rate, and that was talked about in the presentation by Louisa and Julie early on from their work in Timmins. So we see from Sudbury, for example, there was an increase from 28 to 53 per 100,000 deaths, whereas the Ontario average is 11 to 17. Again, I won't go into this except to say that there are three sort of contributing factors. One is COVID, causing social isolation and depression and loss of income and housing and all these other social determinants of health. There is also disruption in willingness to attend emergency departments and opiate agonist treatment clinics and so on. And of course, the increasingly toxic drug supply, which is an adaptation made by the drug cartels, where they're continuing to make increasingly potent fentanyl to create demand and also to meet the demand that they've created. So what do we know about opiate agonist treatment before and during the opiate crisis? Opiate agonist treatment remains by far the most important public health strategy to prevent opiate overdose deaths. This has been shown repeatedly. One systematic review, for example, found that the mortality rate while on methadone was 2.6 per 1,000 patient years, rising to 12.7 per 1,000 patient years while off methadone. So it's about a protective factor of 2 to 3. And in fact, the protective effect is relatively greater in the fentanyl era than before. And this was shown in a brilliant study from BC by Pierce. The relative risk of death while off methadone was 2.1, rising to 3.4 while off methadone after fentanyl use became common in 2016. So what they found was that the mortality rate while on opiate agonist treatment remained stable during the fentanyl era. It didn't increase, but the death rate if you were off OAT did increase a lot. Buprenorphine offers comparable protection against overdose, relative protection against overdose methadone. OAT protects against overdose even in people who continue to use fentanyl. Not a lot of research on this so far, but there was one study, for example, from Rhode Island that looked at people who were primarily using fentanyl. No deaths while they were on methadone, but 4 deaths pretty soon after people left methadone treatment. OAT protects it against overdose by reducing the frequency and amount of fentanyl use. It sort of changes fentanyl use from biological compulsion, people needing to use fentanyl to relieve withdrawal symptoms and more to a choice or a habit. And it also builds tolerance to fentanyl-induced respiratory depression. In fact, all opiates, if taken regularly, especially long-acting opiates, will build to some degree respiratory tolerance. I mean, somebody who uses fentanyl daily, for example, is much less likely to die from a particular fentanyl use than a naive fentanyl user who doesn't use at all and they just use that once. So it's building up respiratory depression, meaning it's a harm reduction intervention. Probably the protection for both methadone and buprenorphine is dose related. In one study, I actually couldn't find the author when I was looking the other day, looked at 20 people who died of an overdose while on methadone, and all of them were on doses of less than 60 milligrams, and half were in fact on doses of 30 milligrams. So it does look like the protective effect is greater once you reach doses of 80 milligrams or more. And then, of course, there's numerous other positive effects of opiate agonist treatment besides overdose death, the reduced crime and incarceration, reduced HIV risk factors, reduced hospitalizations for infection, decreased ED visits, reduced hospital AMA rates. So it's got a pretty, I think, pervasive and profound benefit for people who continue to remain on OAT. But there are some concerning, I think, trends. It looks like the numbers of people on OAT in Ontario have probably increased from January 2020 to March 2021 by about 2,000. This is based on research from our colleague Pamela Lease. But treatment retention rates are low and may be declining overall. 6-month treatment retention rates among patients on OAT in Ontario dropped somewhat from 55.9% in 2013 to 49.6% in 2018. Now, I have to say, for those of you who attended the talk, that great panel discussion, that was looking at treatment retention rates and dropout of OAT in response to the changes in COVID guidelines around methadone carries and so on, and they showed that there was no increased dropout rate. I think what we're going to be talking about here is specifically treatment retention and dropout among high-risk opiate users, that is injection fentanyl users primarily, and also in the first few months of treatment. So people who are stable on OAT are much less likely to drop out than people in their first few months. First month in particular, when the dose is not optimal, et cetera, et cetera. We know that treatment dropout is associated with a very high risk of death, and there are patient factors that are associated with treatment dropout, and this has been shown. Fentanyl use is a major one, as well as concurrent mental illness. So we know that OAT works. But there's also this concern that we're not engaging and retaining patients in treatment, particularly fentanyl users, and particularly early on in treatment. So what are the reasons for that, and how can we deal with that? Well, one is clearly suboptimal dosing. Fentanyl use increases the likelihood of treatment dropout, and again, it's related to the potency of fentanyl. So you need high doses of methadone or buprenorphine to overcome the tolerance, the very high opiate tolerance caused by fentanyl. If you don't reach that high methadone dose, patients will continue to have cravings and withdrawal symptoms. But you can't go up quickly with methadone because of bioaccumulation, has to be titrated gradually. So highly tolerant patients will report that they don't even feel the starting dose of 30 milligrams. And this creates a vicious cycle. Why, if you don't feel it, if the methadone doesn't seem to be helping you, why bother going to the pharmacy if fentanyl is easily available and inexpensive? So if patients don't if they don't attend the pharmacy, if they don't go regularly, then the provider can't increase the dose because the patient has to go on consecutive days in order to get a dose increase. So the patients are stuck on low suboptimal doses for long periods of time, 30, 45, 60 milligrams. And there was a post on the listserv that commented, and honestly, I don't know if this is the accuracy of this, but it was a personal observation that most methadone patients were using supervised consumption sites, that is, they were continuing to inject fentanyl, were on doses of 30 milligrams. So we also know or suspect that clinic practices may affect retention and dosing. And this is the pre-COVID area. We know that some clinics, some providers were requiring patients to attend the clinic once or twice a week for an office visit and to leave a urine drug screen. If the patient missed an appointment or several appointments, then there was a likelihood that they wouldn't be able to get a script, and then they would drop out of treatment. We know that the CPSO standards and guidelines 2011 contained a number of rules which made it difficult to restart or maintain methadone treatment, such as if the patient missed 3 consecutive doses, they had to attend the clinic in person to get a new script. Mental illness and treatment retention is a huge issue. This is a remarkable study done again from BC, which looked at the medication possession ratio. That is, how many days in the week was the patient actually taking methadone versus missing a dose. And they found that their medication ratio for patients who were homeless and mentally ill was only 0.47. In other words, they took the methadone once every second day, which means that they'll never get to an effective dose and they'll continue to use fentanyl. And we know that there's a high prevalence of mental illness among people who inject opiates. For a variety of reasons. Crystal meth use is certainly a contributing factor. So we also have a very, very major problem that needs to be discussed and considered at greater length, is that most patients who receive opiate agonist treatment receive it at community clinics from community physicians, and those clinics are funded entirely by OHIP. Ontario Health does not give stipends to physicians for non-paid clinical work like connecting patients with social services, and does not support fee-for-service clinics with case management. And in fact, I would say it's pretty well impossible, even no matter how dedicated and good a physician you are, to provide care for patients with complex mental illness and psychosocial problems and fentanyl and crystal meth use, etc., by yourself as a physician. We need to work in teams for these kind of complex patients. And yet our system, not only the fee-for-service system itself doesn't support it, and Ontario Health does not give the resources needed for these private clinics to provide optimal comprehensive care. So what do we know about opiate agonist treatment in the ED and other healthcare settings? This is a critical issue. Back in the early 2000s, patients were addicted, who had an opiate use disorder, were mainly addicted to OxyContin, which is, of course, far less potent than fentanyl. Many of these patients were chronic pain patients who had first been introduced to OxyContin in a family doctor's office. So they could tolerate gradual methadone titration. They were stable. They could make and keep appointments at opiate agonist treatment clinics. If they dropped out of treatment or missed doses, they weren't at, they did die from overdose, but not at the astonishing rate that people are dying now. They didn't have there wasn't the same urgency to connect them to treatment. In contrast, people who are using fentanyl now are much more likely to attend the emergency department, much more likely to have life-threatening conditions, overdose, abscesses, sepsis, trauma, etc. So the emergency department, unlike back in the OxyContin days, presents a central and important opportunity to intervene. So this is one study in Simcoe County of 1,257 people who had presented with an opiate overdose. 69% of those had visited the emergency department at least once in the year prior to the overdose. So they were multiple visits to the ED with overdose or other problems, withdrawal, sepsis, cellulitis, trauma, suicidal ideation, etc. So in another study of 6,140 people seen in an Ontario ED for a non-fatal overdose, the risk of death in the year following the overdose was 5.3%. That is a 1 in 20 of the people who presented with a non-fatal overdose were going to die in the next year. So that's an astonishing statistic. Now we know, again, focusing on the ED, controlled trials have shown that giving buprenorphine in the ED is far more effective than any other intervention, which may mean counseling or referral. Even telling a patient, go tomorrow to the addiction clinic on site is not as effective as actually giving buprenorphine in the ED. And a significant proportion of patients will accept the buprenorphine and will attend an outpatient addiction clinic once they've been started on buprenorphine. So this is a retrospective cohort study done at Lakeridge Emergency Department in Oshawa. 88% of 49 patients in opiate withdrawal agreed to receive buprenorphine in the ED, and 54% of those attended the initial appointment at the RAM clinic. The Canadian Association of Emergency Physicians endorses the use of buprenorphine in the ED, yet only a few EDs in Ontario offer buprenorphine on site. That number is increasing, and I'll talk about some of the initiatives for that, but right now it's not where it should be. A national survey that was published last year showed that among Canadian emergency department physicians, only 7% prescribed buprenorphine regularly, even though the large majority reported seeing opiate withdrawal frequently in their emergency department. What about other addiction in healthcare settings? Withdrawal management services typically have been non-medical. So if someone attended the ED, the withdrawal management because they didn't have a source of opiate because they were in withdrawal or for whatever reason, it would just be abstinence and they would often leave. I know of at least one case of someone who was in the withdrawal management, went through withdrawal, tolerated it for about 2 days, left, took opiates and died of an overdose. This is starting to change as nurse practitioners are starting to staff withdrawal management services. Coverage is certainly, it's starting to get a lot better, but it's still inadequate with spotty coverage. But this, I think, will be a game changer if you have withdrawal management services able to initiate OAT. There are hospitals with addiction clinical consult services that are routinely providing OAT, but only a few hospitals have that, although I know Ministry of Health is supporting more and more hospitals to get ACS going. Family physicians are reluctant to initiate OAT or even to accept patients who are stable on OAT, and that's a huge problem. RAM clinics are increasing in number, but many RAM clinics have limited hours. Residential psychosocial programs, a lot will accept patients on OAT, but very few are able to initiate it. And as I said, community with OAT programs or clinics are the major provider of long-term OAT in the province, and they are underfunded because they're entirely funded by OHIP, so it's hard for them to provide comprehensive care. So what do we need to do to strengthen the OAT system? I think the goal, and we need to be clear about what the goal is, that there's two issues. One is access and the other is quality of care. The access is that patients should be able to receive medication-assisted treatment on site and immediately the same day in all healthcare and addiction treatment settings. That means emergency departments, hospitals, primary care, withdrawal management services, shelters, prisons, etc. And once treatment is initiated in an acute care setting, patients should have convenient and low barrier access to ongoing opiate agonist treatment at a RAM clinic, at a community OAT clinic, and ultimately at primary care if they're stable. And this split between OAT and primary care is not serving patients well. If patients continue to get OAT at their clinic, they're not going to see a primary care provider, and they're not going to get the important chronic disease management and screening and prevention. So what do we need to do to create a strong OAT system? I think and this was talked about at the last talk on the panel, I think the first step is that there needs to be a province-wide defining and setting of clinical standards for the management of opiate use disorder in all addiction and healthcare settings. That is to say, it's not acceptable anymore for an emergency department or a hospital or a primary care clinic to say, this is not what we do. This cannot happen. It cannot be that an emergency department or hospital says, we don't provide OAT, we don't have the resources, we don't have the clinicians, we're not going to do it. There has to be clinical standards. This is a life-threatening condition. Opiate agonist treatment is an essential medication. It's an abrogation of a patient's human rights that they aren't offered these life-saving treatments. And so there are standards that have to be tied to funding agreements. And of course, if you have standards like that, there has to be appropriate training and staffing to allow people to meet these standards. And not only that, you need integrated care pathways. So patients can get opiate agonist treatment, whatever the setting, and be able to be smoothly and seamlessly transferred to the RAM clinic, to the withdrawal management, to the ED, to the residential program, to primary care. And this, by the way, is nothing new and nothing radical. This is exactly what happens if someone presents to the emergency department with a heart attack. They get expert intensive care right away, and when they're stabilized, they have outpatient expert care from a cardiologist. They're connected to community rehab, cardiac rehab programs, the dietitians, and ultimately they're back to the care of their family doctor. Now, this is not a pipe dream. This is very, very doable. The overall cost of such an initiative would be, significant, but it'd be far, far less than the cost of the public health response to COVID. And one thing we can say about opiate agonist treatment, and in fact addiction treatment in general, is that it is remarkably cost effective in terms of reducing morbidity, mortality, and healthcare utilization. It would pay for itself, for sure. So what about other aspects of making sure that people get high quality treatment? Well, one is we need to adapt quickly in terms of dosing protocols for methadone and buprenorphine and slow release oral morphine. So the MEDIFY recommendations for prescribing methadone to people who use fentanyl is a good start. A number of the recommendations were designed to make it easy for patients to remain in treatment. Faxing scripts for missed appointments. If a patient misses 3 days in a row, leave a script of 30 milligrams for them at the pharmacy rather than requiring them to attend in person. Have flexibility regarding the frequency of office visits and your drug screens. The terrible problem about methadone is that we have to titrate slowly. But one way around that is to add slow release oral morphine. And we have recommended that you can start 30 milligrams of methadone and add up to 200 milligrams of daily observed slow release oral morphine on top of that. And that will help relieve withdrawal symptoms and cravings, so it will retain patients in treatment. And the dose of SROM doesn't need to be tapered when the maintenance methadone dose is reached, but it could be. There's not a lot of published evidence for this to support this recommendation. I would say that it's, people have for many decades combined opiates, so it's not like it's a radically new concept. And we know from listserv posts and personal communications that clinicians are reporting good results. And we felt, despite the lack of randomized trials on this, that given the urgency of the situation and the cost benefit, it didn't seem like there was any particular risk to adding 200 milligrams of morphine when you're considering that the patients are using fentanyl at a morphine equivalent of something like 20,000 morphine equivalents per day if they're using, 100 milligrams of pure fentanyl a day. So the risks of treatment dropout vastly outweigh the risks of toxicity from methadone and morphine. Buprenorphine or methadone first remains an issue of some debate. There's no question that buprenorphine is safer, and it's also more convenient for the patient. We can't realistically expect emergency departments to initiate methadone treatment. That is, I think, always for the foreseeable future going to be done by providers who have some experience in addiction methadone. And buprenorphine is more flexible and safer in terms of take-home policies and so on. But it is somewhat harder to start. and it's less effective for some patients. Methadone clearly has higher treatment retention rates than buprenorphine overall, particularly for injection opiate users. Therefore, if you would start buprenorphine first if the patient doesn't want methadone or has done well on buprenorphine in the past, or is at high risk for methadone toxicity. The goal is to titrate to the optimal dose as quickly as possible and consider depot buprenorphine, which may, again, not enough research on this, but may have better treatment retention. Methadone should be started if induction onto buprenorphine is unsuccessful, or if the patient starts buprenorphine and drops out and restarts and keeps on going in that cycle, or continues to use opiates in a high-risk manner despite an optimal buprenorphine dose. There are several induction methods for buprenorphine now, and I know there was a workshop earlier on today on that, and starting buprenorphine in the emergency department. I think that it's a matter for the clinician to work with the patient to find the most convenient and acceptable means of starting for that particular patient. The office for ED induction for patients who are in active withdrawal or who are able and willing to stop their opiate use for at least 12 hours and attend the office in withdrawal. Home induction for patients who would rather go through withdrawal and start buprenorphine at home. And microinduction for patients who really don't want to endure withdrawal and are willing to kind of be patient and build the dose slowly up. And then there's, of course, macrodosing, and Dr. Sampson and Belmer talked about that earlier on today. This is commonly used now in California emergency departments where you can administer buprenorphine even when the COW score is not very high. The patient just needs to be alert and starting to go into withdrawal. And the first dose is 8 to 16 milligrams, followed by 8 milligrams PRN, 2H PRN to a maximum dose of 32 milligrams on day 1. And the idea is that yes, this will cause precipitated withdrawal and that it will displace the fentanyl from the receptor, but the full mu agonist effect given by the high buprenorphine dose will relieve those withdrawal symptoms and make the patient feel tolerable. So this is a good fit for the emergency department because the patient doesn't have to be in full withdrawal to start treatment. A full therapeutic dose is reached quickly, and the patient's time in withdrawal is limited. So, like I say, it's commonly used in California. Depot buprenorphine is a subcutaneous injection lasting 28 to 42 days. It has several potential advantages over sublingual buprenorphine. It has a higher and more constant serum level, so it may be better at relieving withdrawal symptoms and cravings, although there haven't been any head-to-head comparisons. There's no need for daily pharmacy visits. It's quite a forgiving medication. If the patient misses a few days or even a week, it's okay. So treatment retention rates may be better, particularly for injection fentanyl users, but further research on that is needed. SRAM is a standalone opiate agonist treatment. It's recommended as third line by CRISM. And it's very good now that we have a more comprehensive menu of options than we used to: methadone, buprenorphine, and SRAM. This is for patients who couldn't tolerate methadone or had side effects with it or couldn't start on it. It probably is of comparable effectiveness to methadone, and the usual therapeutic range is 800 milligrams to up to 1,500 milligrams or more. So improving access to opiate agonist treatment. I'm not going to go through this in depth. I think Kate Hardy talked about this earlier on. There are many local, regional, and provincial initiatives for education and training and mentorship and communities of practice. It's actually very gratifying to see our addiction field is really stepping up to the plate and offering training for each other and for new people in the field. Medify's initiatives include the ED Toolkit for managing opiate use disorder in the ED, guidelines on opiate agonist treatment for residential programs and for withdrawal management services, recommendations on prescribing methadone for people who use fentanyl, the nurse practitioner manual that we're working on, the primary care handbook, and the best practices handbook. Implementation initiatives includes the ED Change Project, where we have given small grants to 5 emergency departments across Ontario to implement buprenorphine protocols. Nurse practitioners working in withdrawal management services are developing protocols and building communities of practice. RAM clinics are working to expand hours, expand access, and build strong connections to the emergency departments. Hospitals are, and the provincial government are funding addiction clinical consult services and patient navigators. And individual clinicians and hospitals are doing groundbreaking work. I'm not going to, I mean, a number of people have made talks today. I won't mention everyone, but it's actually very exciting and gratifying to see. Virtual care systems are being developed. Alberta's virtual opiate dependency program is a good model. They've started 2,000 patients, new patients on opiate agonist treatment in the last year. With virtual opiate dependency program, the idea is you can start buprenorphine or methadone on the same day, regardless of where the patient resides, whether it's home or emergency department or withdrawal management or a shelter. There's a number of participating pharmacies, so a script is faxed to the pharmacy and the patient is connected later on to a primary care provider or a community opiate agonist clinic. So thank you. That was a very, very brief overview of, I think, what is a central issue in the opiate crisis. So I'm welcome. I think there is lots of time for questions and comments.
Yeah, please feel free. I always have lots, but I'm going to start with the first question, which is an interesting one from Angie, about whether there's any research on whether if people want to taper off methadone, there are recommendations about switching to buprenorphine first. And I'm sure without my prompt, that all makes us think about what is, when we think about methadone, we think about trying to get people retained in treatment. But it's really important to think about the fact that there are people, obviously, who want to taper off treatment and how to support them doing that in safe ways.
Yeah, I think that I don't know if switching from methadone to suboxone is more effective than tapering with methadone alone. I suppose it probably is, because withdrawal from suboxone is milder than withdrawal from methadone, that's for sure. But I think we have to be very careful about why and work with the patient as to why they want to taper off. And patients are getting a lot of pressure, sometimes from family members, sometimes from treatment providers, to taper off. Somehow methadone there's a treatment stigma. We know about individual stigma against patients, but what about stigma against medications? And this is clearly that there's a stigma against methadone and suboxone being on it, and I think we need to be cognizant of that. The fact is that what we know about methadone and suboxone is that the longer a patient is on it, the more likely they are to be able to successfully get off it. And that the patients who are able to get off it have accomplished a number of critically important tasks. They have stopped using drugs. They don't have drug-using friends. They're socially stable. They have their underlying mental illnesses have been addressed and treated. They have reasons not to use because they have strong social supports. And that is not something that happens in the first month. It's usually not something that happens in the first 6 months. So I think the first step in considering that question is this in the patient's best interest to taper off methadone or suboxone? Now, if the patient says, I want to go off and, that's all there is to it, there's the primacy of the individual. Of course, they have that right. But we also need to tell them there are certain risks that are attending. The relapse rate is pretty high, especially early on. And if you do relapse opiates, I will be willing to put you back on opiate agonist treatment right away.
I have a couple of comments on that. I know it's your Q&A, but I sort of can't help myself. One is that Melissa Holowati presented a reference this morning in the buprenorphine workshop, identifying the equivalence of buprenorphine to morphine as 1 to 70. We always talk about the fact that we don't have any, good MMEs for conversion. And so I guess I just want to point out that what we think about as low doses of buprenorphine, right, 2 or 4 milligrams, may not necessarily be so low. So I think that the initial studies or reports that buprenorphine was easier to taper than methadone haven't necessarily borne fruit in my mind. I've seen a lot of people stuck on, 1 or 2 milligrams or even a half. But the other thing to your point is linking back to Carol Hopkins' talk this morning about what supports people in coming off OAT. And you really already touched on that, but I just want to reiterate that from her talk and from my experience, especially in the context of working with Indigenous people. It's about recovery is about wellness and connection to land and hope, meaning, culture, and purpose. And that, focusing on medication without focusing on those is ultimately so unsuccessful. So sorry for that little pitch.
No, those are extremely important valid points. Absolutely.
Katie's point in question is methadone has a higher retention rate than buprenorphine. But comparing the two treatment options, does one show superior efficacy for decreasing opioid use? And that's a complicated question, but I'll put that to you.
I think that while methadone has a higher treatment retention rate than buprenorphine, I don't think it necessarily is better at stopping opiate use than buprenorphine while the patient is on treatment, which suggests the possibility that the reason why methadone has a better treatment retention rate is that when patients stop methadone, they go through horrible withdrawal. And so that keeps them in treatment in that way. So it's a good point and a good question. And I think that related to that is, what is the goal of treatment? And I think all of us have recognized that abstinence from opiates is not a realistic goal for many patients. Prescription opiate users, yes, many of them will stop completely their OxyContin or whatever drug they were using. But for injection fentanyl users, many will continue to use fentanyl, even though they're on methadone or buprenorphine. Hopefully, they're using it a lot less and it's more occasional. So then again, methadone and buprenorphine can be framed as harm reduction interventions.
Thanks. I'm going to jump a question and then come back to Josh's, because Sam's question sort of segues on to discussions about different types of OAT. So regarding our conversation in the panel about what we've learned about OAT during the pandemic, how do you view the document on OAT? And I assume that's the methadone guideline, the MEDIFI guideline on methadone with people who use fentanyl, in terms of the balance between firm guidelines and the ability for prescribers to find additional ways to better support titrations for people who use fentanyl. For example, what about more aggressive methadone titrations in people with recent high doses of methadone, but who may have missed 5 days or more of methadone?
Right. That is a great question, and a really good question, and one that we struggled with as a group. And I can give you an example. We struggled with the question about the starting dose of, should it be only 30 milligrams or should we endorse a starting dose of up to 40 milligrams? And in the end, we didn't. We said 30 milligrams because we couldn't find any recommendation or guideline that said 40 milligrams. Except for inpatients. The American guideline says you can do 40 milligrams as an inpatient. Having said that, I am absolutely sure that starting at 40 milligrams in a regular fentanyl user would be safe. And when I worked at Addiction Research Foundation years ago, that's what we did. Everyone was started at 40 milligrams. So the 30 milligrams was done in, that guideline was put in an era of OxyContin, codeine users, primarily, where there was a true worry about iatrogenic methadone toxicity. So I think, though, that what we have done in that guideline is very much, just like the OAT COVID guideline, is the primacy of clinical judgment. If a physician says, well, you haven't used methadone for 5 days, but in those 5 days you were using 5 points of fentanyl every day, and I know you need 80 milligrams or 100 milligrams, and I'm going to start you at 50 milligrams. I don't think that anybody could say that's wrong, that's bad, you should lose your license. I think that given the fact that that patient could very well be lost to treatment altogether and die of an overdose, I think it's absolutely okay for physicians to say, I know this patient, I know they will do well on giving them a higher dose after missing 5 days, and it's okay to do it. However, when you come up with recommendations and you're putting it in writing and you're expecting everyone to, look at it and read it, you have to be more conservative. And you can't, just say, well, just give whatever you want. So that's all I would say to that. I think it's a wonderful thing that the CPSO has gotten rid of their guidelines. I think they should have done it a decade ago, but that's where we are now. And I think it's time for us to innovate, to use our clinical judgment, to talk to each other, to communicate with each other, to try things even if they're not proven in randomized trials. That's what we have to do. That's the urgency, and that's our moral imperative right now, is to respond as quickly as we can to this terrible crisis.
Laura, thank you for your comments in the chat about the evidence that we did find. You're right. There was at least one article that started people at 40, but then the rate of increase was slower. And so people didn't really net out at a higher dose by the end of 10 days than with the recommended titration in that document. And I think that probably adding strom, as you've said, is more effective. I don't think there's really any published literature. The guidance around adding strom to methadone came from the Saskatchewan guidelines, which wasn't published in peer-reviewed journals. I think that's one of the next things for us to do, in addition, obviously, to working with people with lived experience being on OAT to help figure out what the next steps look like. So a plug for our workshop tomorrow afternoon, which is a dive into that document and applying it in case anyone has not registered and still would like to. I think that's possible. I just want to take a step back to a question by Josh, and I think this also came out of the panel, which is how do we think about what standards for quality care would look like as sort of part one, but also how we think about the implementation of standards province-wide. And I know that raises huge questions around systems and finances and individual practice. So I put that to you also.
Right, that is a fantastic question, and I'm glad Josh brought that up. I think that I was focusing on practices like frequency of urine drug screen and methadone dosing and all that, but we know there's way more to treatment retention than that. In fact, what the studies, and there hasn't been a lot, but the qualitative studies, as I understand it, the main determinant of whether a patient attends treatment, besides individual factors like mental illness, is how they feel about their provider. If they think that the provider is on their side, and that's the word they use, they're on my side, they have the best interests at heart, they're more likely to stick with it. And I think that comment from Sean in that OAT panel was brilliant. He said that his provider for methadone stuck with him through difficult times, and that's why he's doing so well today. So the individual relationship with the patient is absolutely key. And I think it's too bad in our system that it's difficult for providers to do that because of the fee-for-service system. The other thing that's critical for, I think, high quality care and treatment retention is the team approach to care. I don't think it's possible for an individual physician to deal with some of the patients who have complex polysubstance use disorders and concurrent mental illness. Yes, it's easy. I have patients that I have known for 30 years who are on methadone, and they are easy. I like seeing them. They don't have any mental illness or anything. But dealing with a crystal meth using patient who is psychotic, who is homeless, who is, needs their methadone dose titrated, et cetera, you can't do it alone as a physician. You need to have a case manager who is working as a team, not someone who, okay, I got you an appointment for 2 weeks with the social worker. No, somebody who's in the clinic side by side. That's an absolute bare minimum, I think, of what you would need in an opiate agonist treatment program. And it's hard for OAT programs to have that because they're entirely fee-for-service. They have to pay for rent and office space and all the rest of it. And this is a huge deficiency in our system that is not funding and giving proper support to fee-for-service. It's kind of like you're off on your own, like they're second-tier patients. And then the other problem, again, is that primary care is not stepping up. They're not, especially comprehensive collaborative models like family health teams. They're not accepting these patients, even though they have the resources to look after them. And so you have a system that's starved for resources, starved for staffing, that is not able to meet the crisis, meet the needs that's going on right there. So in terms of how to do it, I think that the starting point is standards, where Ontario Health says, you will do this, these are what you need, and we will give you the training and support you need to implement these. For example, I think that comprehensive family health teams and CHCs should be told, you will accept patients on opiate agonist treatment, you will prescribe them methadone and suboxone, and you will provide primary care for them. Not, if you want to and please do it, but no, that's in your treatment agreement. You cannot say no in your funding agreement. And similarly with hospitals, and as for community OAT clinics, I think there should be things negotiated with them to give them the case management support so that they can provide high quality care. I think we need deep reform of the opiate agonist treatment system. It's not working well, and it's not meeting the needs of patients well enough. It was fine, I think not perfect, but it was okay in the OxyContin crisis. It's not up to snuff for the fentanyl era.
Some interesting comments about primary care and the funding systems working against what we would like to do. I feel like I have to wear my primary care hat also, and just thinking about all the things that family physicians do and are called on to do, and that it's not only about funding, it's about education, it's about scope, and it's about supports. And I think it will require a pretty drastic intervention to change that. And but partnerships and collaboration, I think, could go a very long way towards doing that. I'm going to jump for a second to a question, given the challenges that we have around accessing care, to a question about virtual care. And because you mentioned that as well in terms of the Alberta model. And it's been suggested that because there aren't enough addiction doctors spread across the province, that there could be access to virtual care so that patients in more remote regions could still be looked after. And I wonder what you think about sort of the pros and cons with regard to not having regional or local care and the relationships and connections to resources that come along with that.
Well, I know it could sound very critical, but I think that it is a problem if you have, some of the OAT providers with extremely large practices who have multiple locations and they use virtual OAT. They're the virtual ones. The patient has to go in person, and they have them in different communities. I don't see that as ideal. And I think that there is a need to build on local resources. I think that an ideal virtual OAT system would start the patient on OAT, but there would have to be agreements with local clinicians and primary care or community OAT clinicians or RAM clinics and pharmacies to carry on the care. I don't think that the virtual care is ideally done in just virtually. I can say, because I've been at home, because I have a medical condition, I've been at home a lot, and I can say that my patients, it's not ideal for all my patients to be seen virtually. It's just not. They need to come in for in-person visits. I think it's better connection. It's better. It's more intensive care for them. They get your drug screens, blood work, and some degree of attention to some of the other underlying medical and psychiatric conditions. I don't think that we could have a virtual system that completely replaced in-person OAT. But the advantage of virtual OAT is that it can connect people right away. People who live in a community where there is no community OAT provider, or who are ambivalent about it and are willing to talk to someone at home but don't want to go in. But the virtual OAT system has to be embedded in an in-person network of providers, of pharmacy, RAM clinics, and community OAT clinics, and primary care.
Thanks. Chetan asked, do we have a sense of the percentage of patients with OUD who have an identified primary care provider?
Right, and this gets to a study that was just done by Tara Gomes, who presented earlier on, in her group, which looked at people who have lost their primary care provider in Ontario through retirement or whatever reason. And it looked at how many of them were able to get a new primary care provider in the following year. The regular patients, the large majority of them were able to get a primary care provider. OAT patients could not. They were far fewer of them were able to connect with a primary care provider, which suggests, it doesn't prove, but suggests that primary care providers don't want patients on OAT. Interestingly, patients on opiates for chronic pain were able to get primary care providers, but not through family health teams, mainly fee-for-service primary care physicians. So I would say that, and there's other studies. One study by Cheryl Spitoff, it was really, really sad. Even matched for social class and education and all that, patients on OAT were far less likely to get screening for, breast cancer and mammograms and diabetes management, high blood pressure control. Far less likely to get control of that than patients who work on OAT. So I think that it's the OUD patients are being excluded from the primary care system. I'm not blaming it all on primary care doctors, but I think it is a huge problem. And the sad thing is that as this cohort is getting older, they're going to die of the usual things, cancer and heart attack and all that. And those are preventable deaths if they had gotten appropriate primary care.
Well, you're right. They die younger, right? Because of all of the things impacting their health and the lack of care. And we will soon have sort of a little subspecialty in terms of older people who've been on methadone for decades. I found it interesting in Tara's article that it seemed that those patients on opioids were accepted into fee-for-service practices rather than capitation-based programs. And I don't have a good explanation or understanding of that. But yeah, anyway, it certainly highlighted that barrier for sure.
Yeah, and in fact, Rick Glazer had shown that patients with mental health diagnoses are more likely to be looked after by fee-for-service providers than by collaborative, comprehensive family health teams.
Yeah. A comment from Megan about working in an ED, that they often have to advocate for other health issues to be looked at, that the OAT or substance use takes center stage, even if they've come to the ED for something that's completely different. The other conditions often become ignored, and I think that's true. And I think it is really unfortunate that so many people are seeing a physician so regularly for their OAT, but not having other health issues looked at. And I can understand why, for some people, in an emergency situation, their OUD could be take primacy again for fear, I guess, of losing that and of all of the things that go along with that, or because of complications of the OUD.
Absolutely. I've had patients who tell me, I never tell anybody when I go to the ED that I'm on methadone. If I go with, even if I have no interest in opiates, I don't want Percocet, I have abdominal pain, I have a cold, I don't want to tell them because I'm treated differently. And I think I'm sure that that's true.
Yeah. Which doesn't help if it comes up after the fact, right? In terms of trust and communication issues and relationship.
True. Yeah.
But speaks to so much stigma within our profession and the healthcare system and the structural issues in the system. I'm happy we have a couple of minutes if people have other questions or comments. I'll take the opportunity to remind everyone to please complete their evaluation. All you have to do is click on that red button on your screen. There are evaluations for each session that we're asking you to do, as well as an evaluation at the end of the day for the full day. And after this session, there will be a 15-minute break, and then session 4 for those who are not in the workshop. There are 2 sessions. One is on reimagining philosophies of care, hiring, training, and mentorship of nurses in CTS. And the other is a program called STOPS, a journey of grassroots overdose prevention from Northeastern Ontario. Both sound great. After that, and our wrap up, there is yet more. There are networking sessions for those who have the stamina to stay on. We hope that if there's a topic that's of interest to you, that you'll find a little bit more energy. If not, we understand, and we'll hope to see you tomorrow morning. Thanks so much, everyone. Stretch your legs, grab a couple of extra minutes, enjoy the break. And if I overused the word physician, I'm just looking at the last comment, rather than providers or prescribers, please accept my apologies. I will acknowledge that that comes from my experience and bias and really needs to be shifted as well. So thank you for that call out. Really important and necessary.
Thank you all. Thank you all.